Thank you for your introduction, and we will change a lot the subject of the course. It's very different from what Kiel presented. So just before starting anything, I want you to just remember, I just wanted to remind you that the childhood cancers are not the cancers that are occurring in the children, and it's not at all the adult cancers. Most of you already know. I just represented here the distribution of the adult cancers, and you can see that we have in France 200,000 cases per year. They are, I have the image there. They have this distribution with a median at 70 years that you know, and we are just interested in the 15 first year. What I want to say is that when you look at this distribution of the cases, of course you have very small numbers compared to that of adults. It's the results from our registry. So we have 500 cases of leukemia each year before the age of 15. And of course, the distribution of cases are not at all the same, as you know. And and interestingly, what is important is that you have the carcinoma at the bottom of the curves that are starting very late, and they are the most important form of cancer in the adults. And you have this peak of B-cell precursor ALL, you know well, that is characteristic before the age of 6 years. And most of the neuroblastoma, women's tumor and hepatic tumors that are occurring before the age of 6. So you have two realities there that are important for etiological research. First, they are not carcinoma. So the history of exposures that leads to the occurrence of a carcinoma in adults is not relevant here. The second thing is that a lot of cases, half of the cases occur very early. So we think that there are very short time for them to occur, and not a lot of hits to launch them. So this is all the carcinogens that are known in the adults. You have here the class 1 carcinogens, those who are completely established as carcinogens, genetic predispositions, some virus or bacteria, some lifestyle exposure like smoking, alcohol, and processed meats, ionizing radiation, some environmental exposure like background natural radiation for radon or gamma ray, sun and UV, passive smoking and air pollution that are on the general environment. And a lot of the second column, a lot of carcinogens that are found in the occupational environment that takes several years, several mutations to do the carcinogenesis. And finally, radiotherapy and chemotherapy that are recognized as class 1 carcinogens. And I showed this because knowing that have allowed a lot of preventive measures and on the occupational places, of course, but also vaccinations, also genetic detection, and also campaigns for stop stopping smoking or alcohol drinking, you have a prevention possible when you find this kind of factors. But most of them, they are not possible for the children who are most often not carcinomas. Some of them, however, those with a red stars, are of course present in the children risk factors, genetic predispositions, EBV and hepatitis B virus, ionizing radiations with high level exposures, and the blue one are those which are not completely proved but are suspected or are of interest in the child. And of course, radiotherapy and chemotherapy. I added the class 2 carcinogens, those classified as possible carcinogens that are pesticides used, and the electromagnetic field that are generated by the electric currents. So it's what we know and what we had classified as carcinogens, and most of them are not, most known carcinogens in adults are not risk factors for childhood cancer. Just to remind you how the evidence of carcinogenicity is done by the IARC, WHO. They have a discussion. I will zoom it. You have a panel of experts, a large panel of experts that who are meeting once the literature about an exposure is sufficient to be analyzed. And you have some people looking at all the literature about human cancer, and they are working on elements that give proofs of exposure. A part of the panel is working on cancer bioassay and make the synthesis also, and also classified the study according to the quality of the study and according to the size of the proof they bring, and some mechanistic data. And the whole thing give the classification, you know, of carcinogenic group 1 or group 2A for probably carcinogenic, or possibly carcinogenic group 2B, or not classifiable group 3, which is not often used. But you see in the first column that the first column is the evidence coming from epidemiology, and it is only sufficient to classify the evaluation as a group 1 carcinogenic, even if you have no evidence of cancer of experimental for experimental studies or for mechanistic evidence. So sometimes it was a case, for instance, for smoking, which was discovered as an adult risk factor without any biological proof. Well, like I said, once you have done this kind of synthesis about the environmental exposure, you can establish whether the relationship with the cancer could be causal, and if you can do prevention in removing the sources of exposure or reducing the emissions. It's what have been done for diesel exhaust. Protecting the house, it's what is done for radon. Protection of individuals, like it's done for UV, or vaccinations, like for HPV. And you can have also specific screening and monitoring, like for oncogenetics, or people exposed to radiotherapy or chemotherapy, or those who had high occupational or accidental exposure, like in Chernobyl. So this is the interest of this classification about causal role of these exposures. Before telling anything about what we know or don't know about childhood cancer risk factors, I must say that saying that childhood cancer are rare diseases have important consequences on the design of the study that we can do to evidence risk factors. You know, for instance, you want to study the cases from before they occur, from the conception or from the birth, and because you are conscious that a lot of things are occurring before birth, so you may want to have a cohort, and this is the figures of the number of cases you are expecting before the age of 15 for a cohort of 200,000 births when they attain 15 years. So you will have less than 500 cases expected in the cohort, and you will have for some cases a very small number. And within these numbers, we will have to compare those who are exposed and those who are not unexposed. So you see that this is a very difficult, a difficult exercise. So we all want to have a cohort where all the events before the disease could be seen. But this is limited because having the sufficient numbers needs a very, very large cohort with a lot of information collected. Another way to say that it is a rare disease is to see, I took the example of France. In France, we have 1,800 cases per year, and for a population of 11 million of children that who are living in 35,000 municipalities. And the number of expected cases in municipalities are for more than 1,000 municipalities, one case every 1,000 years. For 15,000 municipalities, one case every 100 years, etc. And only 10 big cities are expecting more than 10 cases. This is something to have in mind, because we are often facing the question of clusters, and parents are very often eager to have an explanation to these clusters that can occur also by chance. But you see that having only a geographical study, an incidence study, will not bring a lot of information. So the rarity of the disease is good for the children, of course, but it's a limitation for this kind of study. It's why we almost all time conduct case control studies. I mean, studies where we include the cases once they have already occurred, and control that are resembling them, and that could be included if they had the disease and that are from the same population. And the consequence of this is that when you do the study, you have to reconstitute all the events that were before that appeared before the disease occurred, and this is the difficulty, because you have only questionnaires and not any marker present in the child up to now that could tell you, yes, this child had been exposed to pesticides, or this child has been exposed to radiation, or so on. So we don't have any trace. What we can do is to observe what the parents recall, and what was his history of residence and to find what happened. I wanted to just tell a small word about the incidence rate. I will pass this one. This is a question that a lot of clinicians and a lot of people and a lot of journalists always say. It's if the incidence of the disease is rising, this is a proof that the environment is involved, and seeing that the incidence rates are increasing in most parts of Europe and in most part of the world. But today I chose to have a European map. I wanted to explain that, for instance, I take this example from the paper on malignant CNS tumors. Here you have the annual percentage change, the curves. You have in orange the Western countries that are covered by one or several registries. In green, those that are considered the South. In yellow, those that are considered the Eastern, and all the others are considered Northern in this study. All the studies had were stable with time, but the West was not. And I just wanted to recall that in France, the registry of solid tumor, the national registry, was created in 2000. So before, the information on CNS tumors was only given in our country by very small registries, not small at all for adult cancers, but small for children. And if a department, one of them is, we're expecting three cases of CNS tumor in a year, missing one has a big consequence, and it's 1/3 of the cases that are missed in the calculation of the incidence rate. So sometimes you have to consider that a trend can be also explained by the change in the measurement, in the way the incidence is measured. So just have in mind that trends in incidence can reflect the real changes in incidence, changes in the incidence measurements, the example I just took, or change in the diagnosis. So some classes of diagnosis are changed and they are no more counted as brain tumor, or no longer counted as neuroblastoma. They have changed their category, and you have different trends due to this. And I want you to have the idea that the absence of trend in incidence does not mean absence of environmental risk factors, and that trend in incidence does not mean environmental risk factors. You are not doing the surveillance of risk factors by the incidence. It's just an alert that can be given by the incidence. And just to illustrate this, these are the curves of lung cancer. And you should not say that the decrease in incidence of lung cancer does not mean that the environment is not involved in lung cancer. Of course, a lot of environmental factors are involved in lung cancer. I think that for most of you, this is a question, and this is something that the journalists or the parents will discuss. It's why I wanted to cite it. Well, the second element which is important for understanding the risk factors is that the childhood cancer starts, for most of them, or for many of them, before birth. So you have sometimes one hit is sufficient to launch the disease, but sometimes 2 or 3 hits. So for us, you have 2 times windows that can be important. The prenatal, maybe an interaction with the first hit, and in postnatal, the last hit. What is targeting the last hit is very important too. So most of the studies will focus on the perinatal period or at the diagnosis period. Some suspected risk factors we have seen just before that: EBV, HPV, chemotherapy, radiotherapy, and high-dose ionizing radiation, and some genetic factors were involved in childhood cancers. And I just heard that Kjeld just before have also spoken about the polymorphisms that are in fact producing very interesting risk factor, with sometimes some alleles having a relative risk of disease of 1.5 to 2 for 40% of prevalence. So those are the place taken by this polymorphism could be important. It's not a confidential thing. It's a relatively important place as a risk factor. But is it alone? Is it with other factors? It's not clear how to count their contribution. What were the other exposures of interest? We have of course other infections, and there have been a lot of works in the clusters, out of clusters, in the trends, to find new agents in the tumors, and particularly that could be stimulated by population movements. And up to now, none have been found. The low and very low dose of ionizing radiations were also good candidates, and you have the scanners and the background residential exposure that are suspected. Parental lifestyle, we have found that preconceptional paternal smoking could be a risk factor for ALL and AML, for both leukemia. Exposure to pesticide, high pollutants, perinatal characteristics also, with area T and C-section, increased fetal growth, and maternal folic acid supplementation as protective factors. I will not speak on the perinatal characteristic, and I will just say a word on the early immune stimulation and allergy. Well, to begin with, ionizing radiation, you know that the proven carcinogenic effect, this is a logarithmic scale of exposure. Proven carcinogenic effects are with very high dose radiation, so you know, Hiroshima and so on. In the Chernobyl catastrophe, in the Chernobyl disaster, the effect in survivors are only seen for thyroid cancer in Belarus and in Russia, but mainly in Belarus and maybe in Ukraine. So it's only thyroid cancers that have been found increased, even not leukemia up to now. Although the increase is, the exposure was important. One log lower is the exposure to the scanners, and we had studies showing that the risk of leukemia and brain tumors were increased in children who had a lot of scanners, and they were published almost 10 years ago. And there are other papers now working on this. But as you can understand, a very important thing now is the indication bias. It's not easy to control because, for instance, when you are in a family with a neurofibromatosis, you can have more more scanners than that other children, and a lot of cases included in the French study paralleling this one were found to have a predisposition that was an indication for the scanner, and that could be related to the outcome. So this is something that has been controlled, and that is not easy to control, but it is very important to know if really scanners induce brain tumor and leukemia, and to whom. One log lower are natural background ionizing radiation with radon and terrestrial gamma rays. We have done recently a study in France with 10,000 cases of acute leukemia. We had modeling of the exposure based on campaigns of measurements and mapping of the uranium potential in the earth, and all these exposure, all the maps were co-created and for radon and for terrestrial gamma rays, giving a grid of exposure for each geocoded address of the cases. It could give to each point an exposure. And what we see here, I don't show all the results, but this one is the estimates of the cumulative red bone marrow dose related to the acute leukemia. And what you see is that we found exactly no association, because it's like you read this like a relative risk. It says when the result is 1, that the risk is the same for the exposed than as for the unexposed. So there are still discussions, but in France, on 20 years, we can say that no association was found with these exposures. Another question is related to the outdoor air pollution and childhood leukemia. We don't have so many studies yet, but we see that this meta-analysis published 3 years ago showed that at diagnosis, 14 studies were analyzed and showed that there was an increase in risk of 30%, 1.32, for the children who were living close to high density traffic, and compared to those that were more far from the roads. The indicator of benzene exposures were found associated with AML in some studies. I think that my own studies have good weight in these results. And also nitrogen dioxide was not associated. This is not a measurement that you do at the place of the cases, because when the case is included in the case control study, when you see him, usually you cannot be too much active. You cannot go at his home, and you cannot do the measurements at that time. It's very expensive, and you have not participated. Just half of the people can participate usually. So this is based on modeling, and modeling that are using the knowledge of the roads, of the traffic, of the number of cars that goes on these streets, as there are detailed classifications, and on satellite data and a lot of database that allow to make land use regression models that are used for this exposure assessment. So to know, we have a hypothesis that at least air pollution could be associated with childhood leukemia, and that is one thing we have to to check and to continue to investigate. Another risk factor that is recurrently shown associated with leukemia and also brain tumors and also embryonal tumors, it's pesticide use by the mother during pregnancy, particularly insecticide use. You have here a meta-analysis, and what you see from the meta-analysis is that most studies have estimates that are at the right of the line that says the cases are like the control, the one. So it's an estimate of 1.4, which means an increase in risk of 40%. And there is a big weight. I just show the arrows for the Bailey and et al. These results comes from the consortium CLIC, the Childhood Leukemia International Consortium, with a lot of studies with pesticide exposure. So we have also some indications of an increase in risk with insecticide exposure by the use of the mother during pregnancy. But we have no detail on the mark, on what insecticide is that, etc. So there are a lot of things to understand. This was true also for CNS tumors, like you can see. The next direction we are going on is not only what the mothers use during pregnancy, but also something that is also very often raised by the populations and by the parents, that is the exposure to pesticides due to proximity to croplands. And this is not that easy to study, because you have to find the indicator of croplands at the very small scale. And this is, we have done a cartography based on different sources of exposure, from declaration to the tax, satellite view, and geographical mapping. And what we have just up to now is an increased, a very small increase in incidence of acute leukemia in the places where the density of viticulture, well, is the highest, and viticulture is one of the culture where the use of pesticides is the highest, and it lasts the longest. So for each cases in every cases in France, we were able to exactly define what was the culture within 1 kilometer, but I will not give you the reason, because the analyses are that are ongoing, in progress. But I just wanted to show you that this is the only way that we can use to conclude about the fact the exposure of the people living close to the crops, and after we have to infer on the pesticides that are used on this. You cannot just be based on, you cannot just have a report from the parent that they are living close to a vine. It's very important to have comparison and to see how should be the incidence at this place. Lastly, I wanted to go on the question of infections. Just for a recall, we have the historical question of the Burkitt lymphoma in Sub-Saharan Africa. This is very important to see that it was also very much correlated with malaria, which is a cofactor. And of course, such examples as raises the question of what are the cofactors in other countries, and are there other kinds of epidemics that could be also related to exposure. So we have the question of COVID that help us to ask the question for this virus, but a lot of questions are asked. Well, for my last question is on the Greaves hypothesis that maybe some of you know. This is a model that Mel Greaves proposed 30 years ago, saying that maybe the B cell precursor ALL could be due to a delayed exposure to the normal common infections that occur in all the children, and that being in a more and more clean world could have created this disease and have made the peak of incidence of leukemia, with an increase in risk at the period when the children are going to school and having their first social and intensive activity. So the idea of Mel Greaves was this one, and during these 30 years we had a lot of studies that supported this. Of course, biological studies that show that ETV6 ranks 1 transcript appears like an initial event, and also hyperdiploidy that could be in some cells before birth, and that second hits can appear at the consequence of some later exposure, delayed exposure to infections with an immune stress, where these first pre-leukemic cells could have an advantage and have a new mutation and new mutational event, like CDKN2A or ICAROS. And this is just what the epidemiologists have found. You have here, as usual, the vertical lines that is used to define when the case and the controls have the same risk. And you see that this time all the studies had estimates at the left of this, that most studies with standardized, we have standardized a lot the definition of daycare, but we found that there was a reduction of risk for the children who were daycared. We also have studies showing that it's hypothesis that the children that were born after a pre-labor cesarean were at increased risk of leukemia, which would be a lack of contact with the maternal microbiota, vaginal microbiotes. And also there are discussed effect of breastfeeding, prolonged breastfeeding, with the hypothesis that breastfeeding also influences the microbiota and the immune stimulation of the child. So we have, and also the number of infections. I don't show all the studies, but these are the synthesis of the summary of 30 years of research that have led to the conclusions that yes, the situations where the children were more exposed during the first year to infections, they were more protected against the B cell precursor ALL. Well, I think it was my last slide, and I hope you had an overview of the.
We did, Jacqueline. Thank you very much for your insight into the environmental causes of childhood cancer. And indeed, as you pointed out, maybe 15 years ago, the studies from the States, when CT scan was routinely introduced to the clinical practices, showed increased rate of childhood cancer, because for every abdominal pain, the CT was used like a superior diagnostics, mostly by surgeons. I hope there are no surgeons in here today. We are only clinicians and geneticists. But nowadays, yeah, we are realizing how precautious we should be, as the old Latins would say, primum non nocere. So also from our side, to keep the kids safe. I have two questions, and I would like to open the discussion, and please feel free to ask anything. The first question is regarding the better and more approachable or available diagnostics. As you said, journalists are running with the numbers like the childhood cancer is increasing. Is it really increasing, or we are now better in diagnostics? And my second question would be about migrants, and not only the migrants as people who left their country, but also migration within, for example, Europe. How is that attributed to the national cancer registries?
Oh, for the first question, it's easier. It depends. We have all the things are true. We have sometimes maybe we have real increase in incidence. I'm not sure, but a lot of in a lot of situations, and particularly in the low income countries, what you see is that when you introduce, for instance, IMR, how do you say RMI? For the diagnostic, you say RMI maybe. Well, yeah. I don't remember. Yes, and before it was scanner. You have had an increase, a very neat increase of in the brain tumor diagnosis, and they were included in the registry. So there was directly a translation into it was an increase in diagnosis, and it was an increase in the catchment by the registry. But also you have a reorganization of the network of the oncology, pediatric oncology services. In France, for instance, at the end of the 90s, we had organization with certification, and then the cases were in a smaller number of services, and it was much easier to catch them in a registry. So you have some side effects that were not
reflecting the numbers.
Exactly. Just because it's easier. You have also the electronic files that helps also not to avoid missing cases. So finally, you're right. In a large number of cases, some diagnoses are better, and this is also why we want to know whether there are inequities in the access to the care that could explain that some cases are detected before others. This is also a possibility, at least in many countries. And for your second question, in the registry we have, in fact, the place where the children were born, but we never look at at the relationship with the incidence for them. We never do that. You know, in France, mostly you are not allowed to have anything about race or ethnicity, and I mostly agree with this, in fact. But we lose this information that you are. I think you are asking about habit or about genetic, but both of them are important.
It's just according to the overall numbers, because when you have the huge migration, then it's contributed to the country who registered.
Oh yes, no, this is not, no, just for this, it's easy, because if they are in the census, they are included. So we have the same rule for the inclusion in the registry as in the census. So when a child has been for 6 months in France, he is counted in the denominator. So he is, so we don't have excess, and we don't have so many immigrants, in fact.
And we have Jürgen raising hand, please.
Yes, thank you. Thank you, Jacqueline, for this very brilliant presentation. You have shown us each corner, I think, where you can get exposure to get out cancer, or which are risk factors. The only thing what I missed was this presentation was about more or less hard factors, chemicals, and so on. Did you also investigated soft factors like mental health during pregnancy, or changing working models? Women must now work. My mother, for example, 30, 40 years ago, did not work during the pregnant, as she was pregnant. Is this possible to
this is very difficult. In fact, we tried, and most of the case control studies tried to have this kind of information by the questionnaire, but it happened to be very difficult to be reliable. And the reason why it's well assessed or not can be related to the disease. So it's something that could be given by a cohort more than by a case control study. We are trying to have a lot of events in the life of the mother, but the mental illness are only those that are declared to the health insurance will be traced. If it is not a very clear disease introduced in the classifications of the health insurance of the hospital stay, it's very difficult to catch it. But I remember something, maybe 15 years ago, in one of my studies, the clinician told me that their impression was that a lot of children were ill after their parents divorced. They saw more and more children with divorced parents, and we looked at this, and we had the comparisons with the controls, and it was exactly the same number, but the divorces were increasing. The same for ART, and it's very difficult. Your appreciation, your own appreciation of what you see in the parents when you have a small number of parents can be the reflect of what is in the general society, not that you think that it is attributable to, or that it is related to the disease. It was also what was most parents think that vaccination can be related to the disease, because a few months before they were vaccinated, but the children are vaccinated all the time. So there are fake associations that are often reported by the parents, and sometimes only a very, very small examples can be can be observed, but if really there are relationship with what happens to the mother during pregnancy, it's very, very difficult to have the good design to observe it and to answer really to the question.
If you look to premature birth, then we will all maybe agree that this is a risk factor to have stress during the pregnancy.
Yes.
If we look to cancer, maybe there is some.
Yes, but you know,
depending on going from one to the next day, and if a baby with 1 year has a tumor, then we have to look even to the pregnancy phase.
That's but if you consider, depending on what is your definition of prematurity, you have 2 to 5%, 2 to 5% of the general population that is born at less than 28 weeks, I think. It's if you have small number of cases, and within this 2% of the cases, it's not easy within this category to see if there was risk factors in the mother. So again, you need big numbers, and we have some cohorts on prematures, and some birth cohorts in the world, and this is something that could be better obtained by pulling this